Good afternoon. My name is Greg Colbath. I'm an orthopedic surgeon with the medical group of the Carolinas with Spartanburg Regional, and I specialize in shoulder and upper extremity surgeries, also shoulder reconstruction. I'm fellowship trained with upper extremity as well as sports medicine. But one of the questions I've been asked most often is I've heard that shoulder pain is one of the most, shoulder surgery is one of the most painful things to go through. So hopefully during this webinar, we'll be able to talk about some of the misconceptions on that and know that you don't have to go through shoulder pain alone, and that we are here to help provide great care for you and also help you get back to doing what you want to do. I've been in the Spartanburg area for about 12 years now. I finished my training underneath the mentorship of Dr. Richard Hawkins, and have been continuing to practice in the Spartanburg area and love what we do. So we're going to give you a good overview over the next 20 minutes of shoulder pain and some of the presenting symptoms of it, and also how do we treat it, all the way from simple measures like exercise, but also non-operative measures. And then in the event that you did need surgery, walk you through some of those scenarios that you might encounter, you or some loved ones. So some general overview with some shoulder anatomy. Our shoulder is one of the most mobile joints in the body. So we have an incredible arc of motion with this. And if you just think about this as like a ball and socket joint, our muscles and our tendons basically function like pulleys and levers to help guide that and allow you to do very complex motions, reaching behind your back, overhead activities, lifting and grabbing and pushing items. So a lot of complex movements, and you have about 20 to 30 muscles and ligaments all crossing that one little joint. So it gets a lot of wear and over our lifetime. So there's a lot of common causes of shoulder pain. Right now we're in the middle of football and hunting season and wedding season. So I've already seen a fair number of shoulder injuries related to all three of those entities here this week alone. A lot of times it can be a trip and a fall. Other times it can be from overuse injury. We see a lot of that with a lot of the factories and supply chain that we have here in the upstate. And so a lot of factory laborers are constantly coming to our office with overhead use injury. And as we age, we obviously have some degenerative symptoms as well. So those can present as either osteoarthritis or rotator cuff tears. And we'll talk about the difference between the two of those. And it could also be kind of an inflammatory or hereditary issue, like with rheumatoid arthritis. So age can definitely play a role in this, our sex, our genetics. So a lot of times patients will say, oh, yes, my dad had arthritis, or my mom had really bad arthritis in the shoulders. And to some degree, there is a genetic component to some of the arthritis that we see. And it could also be related to our nutrition status. If we're not active, if we haven't been taking good care of ourselves, then this can certainly create more issues with shoulder and immobility, just like it would for a hip or a knee. Obesity can, and if you've had a prior injury or a prior sports injury or a prior motor vehicle accident, those things can all create some early signs of arthritis or early signs of rotator cuff tear. So as we get older, we naturally have some breakdown of our body's machinery. And so some of the statistics would show that some of the studies that we've seen have actually seen that rotator cuff tears in patients over the age of 65, we actually have about 50% rotator cuff tears if you were to get an MRI of somebody's shoulder and look. Now, they may not always be symptomatic, they may not always be painful, but there is either radiographic signs of it or MRI signs of some early rotator cuff tears. So that's sort of the tough challenge for us, is to figure out which ones need treatment and which ones people can live with. So as we get older, this becomes more and more prevalent. This is a representative x-rays of a shoulder, a left shoulder. On the left side, you actually see the normal shoulder. So you can see the ball and the socket, and you can see a little space between that ball and socket joint. And then on the right side, we're starting to see what I would call moderate arthritis. So you start to see some bone spurs on the side. You see loss of the joint space. You can no longer see right through the x-ray. So this is moderate to severe osteoarthritis. Now, surprisingly enough, I've seen many patients who've come into my office with an x-ray that looks like the one on the right, where you have severe arthritis, but they are completely asymptomatic, meaning they don't have any symptoms, or they have very minimal symptoms, but they're still able to do, by and large, most of their activities of daily living. And we call those ADL. So they're able to wash, bathe, feed themselves, they're even able to work, and they have very few symptoms with it. I've had many weightlifters who come in with an x-ray that looks just like the one on the right. And again, they're quite functional. So just because you have arthritis doesn't mean you can't live a productive life. When I see a patient like that, some of the things we'll initially start talking is what are some non-surgical options? Obviously, they're still active. They're in the prime of their life. They want to work. They want to deer hunt, or they want to do other activities such as that. And so they are still able to do lots of activities. So we want to just basically kind of focus more on pain control for them, or maybe improve some of their function. So a lot of things we can outline for them are rehab, and that can either be through a physical therapist, or it can even be through a home exercise program. We give them education as far as, hey, here are the things you can do, and really you shouldn't have too many limitations with whatever type of injury they have. And then sometimes activity modification is good. So if they've been lifting 350 pounds on a bench press, I'd say, well, you can still do that, but maybe we can modify some of their lifting routine, or maybe some of their overhead work routine. So coming up with solutions like that is a challenge, but it's a lot of fun to be able to work with a patient and give them a roadmap for a better course, so that maybe they've got a little bit more longevity of that shoulder. Anti-inflammatories are excellent not only for hips and knees, but also for shoulder pain. And a lot of times we can also do a steroid injection for patients to see one, and we do it for two reasons. One is diagnostic and the other one is therapeutic. So if I inject in the shoulder, the point where we think you have an issue and your pain goes away, and we can test you and say, okay, your strength is now better because you're no longer having pain. That's great. And if the steroid then can help with the inflammation and get rid of some of that, then it's also therapeutic. So sometimes when we do these injections, there's two reasons for that. So we've proved that that's where the source of the pain is coming from, and two, we're also helping to heal or alleviate some of the inflammation. In addition, we're often able to give I would say, like the injections, those are very helpful, but we can't just give those to you constantly. We have to space those out. I like to use those sparingly. And again, more for diagnostic, therapeutic, rather than sort of the end-all solution for the shoulder pain. A lot of people ask me about biologic injections, and you've probably seen a lot of this if you've read in the newspaper or listened to the radio, stem cells. And so we get asked that quite often in the office. And so stem cells are something that that does show some promise, but is not FDA approved at this time. So if you do hear claims of stem cell injections from other facilities, buyer beware. That is not FDA approved, and a lot of times that is being used off label. So I would certainly continue to look at that, but it's not something that is ready for prime time at this stage. So we're waiting for more evidence-based medicine to prove that that is effective and worth our patients' treatment plan. So there is also some other injections that are not have been shown to not be helpful, and those are like the visco supplementation injections that are actually quite helpful in the knees. It doesn't work as well in the shoulders, and that's not approved by most insurance plans. So what are some of the surgical treatments for shoulder arthritis? Well, there's kind of a stepwise phase. Sometimes we can do arthroscopic treatment, and that would be what most people would describe as like a clean out and a debridement, where we remove some of the arthritic tissue, we remove some of the inflamed tissue. And then if it's, and that's generally very effective in getting patients who have early arthritis function that they need and they're able to get back to and what they want to do in a relatively short period of time without a lengthy rehab, and they're not in a shoulder sling for a lengthy period of time. However, if they have very severe, moderate or severe arthritis, then often they'll need a shoulder replacement. I'm going to walk you through a couple of scenarios in a little bit on what that would look like. One of the really neat advantages that we have in our office is ultrasound. Most of you are probably familiar with ultrasound technology from maybe the OBGYN's office, and it gives us a great ability to look inside the womb and see baby. Well, it also, as a shoulder surgeon, gives me an incredible ability to look inside the shoulder and see if you have a rotator cuff tear, see if you have inflammation, and also see if there's arthritis. And so we're able to do this dynamically in the office. I can bring the patient's arm through range of motion, and we can look at it and look on the screen. The other nice thing is we can do it right there in our office. It's non-invasive, and I don't have to worry about getting pre-approval from the insurance providers. And so having that right there at our disposal, and then also seeing it on the screen and be able to walk through it. And one of the downsides of having getting the MRI is I have to schedule that for you. You then have to go sit in the MRI tube for an hour, and then you have to come back and we need to talk about that. With the ultrasound, we can do roughly the same amount of care and ability to look inside the shoulder on the ultrasound and walk through it with you on the screen right as we're there in the office. I can also do injections and see that I can do that, place the needle exactly in the spot where we want it and look at the screen and demonstrate that. So really, it's been an amazing tool that I've used for the last 10 years that I think is very effective in our office, and our patients love it. They really, I think, like to have the education feedback, and rather than have to look on a poster or a video screen, they can see their shoulder real time as we're moving it around. So it really helps them understand the process. A lot of people ask about what is arthroscopic shoulder surgery. It's very similar to the laparoscopic procedures that the general surgeons do inside the abdomen. But with arthroscopic surgery, that basically just means we're using a scope and we're looking inside the joint. Arthro means joint in Greek. And so arthroscopic is just look inside the joint. And so it gives us a very detailed view, and we're able to use fluid as our medium. And so we use a small camera about the size of a pencil. We make a small portal on the side of the shoulder, and then we can look in and get a very good detailed view. I can then take some instruments from another portal, like a probe or a little a retractor, and we can move the tissue around. We can do a very detailed inspection, and it's very minimally invasive. So we can do this outpatient. Sometimes it takes more time to do the paperwork and charting than it does to actually do the surgery itself. And the patients generally have a quick recovery. I've had several surgeries that we've done recently though, where I have the patient in a sling for a few days, and then I tell them to go ahead and wear that for comfort, and then get started with physical therapy the next day. And I have patients coming back into my office 2-3 weeks later, completely out of a sling. Their wounds have healed and they're back doing what they want to do. So that type of recovery is something that we didn't see 15-20 years ago with open procedures in hospital, hospitalizations. And so there's a lot of advantages to this, particularly with COVID, when we have so much disruption with our surgery schedule. This gives us a great option to treat the patient in a minimally invasive fashion, outpatient, and they can go home and recover just as well as they would in the hospital. And in fact, I think having an at-home recovery is advantageous to most of our patients. So for a shoulder replacement, this would be reserved for somebody who has severe arthritis and wear and tear of the joint. So that has been worn out and no longer have a smooth gliding surface of the joint. And this is becoming a more and more frequently performed surgery because we have an aging population who are doing more. They're active. We're all part of the boomeritis, we've all heard of the boomer population. And so they're having boomeritis. They're living longer, they're doing more, and they want to play pursuits, golf, tennis. And so they're doing a lot more with their shoulders than maybe you saw with the elderly population 30, 40 years ago. And so we've had a very high success rate with these shoulder replacements. And it's just something that I really love doing, particularly with our older active population who want to go back and continue playing these pursuits and being involved in these activities. So basically for a shoulder replacement, we're replacing the ball and the socket. So we have a plastic portion that we use for the socket, and we use a little metal head for the ball and a little stem to secure that. And then we're able to relocate the shoulder. I can do this either in an inpatient setting or an outpatient surgery center. And we were able to do this within about an hour and a half. You're in a sling afterwards. And as soon as that wound is healed, which normally takes about 2 or 3 weeks, we have you started with physical therapy. And I have a lot of these patients back doing what they want to do, pain-free within about 6 weeks, which is really remarkable to think of that recovery time, 6 weeks back doing what they want to do. And most of the patients will say to me, "Why? I don't know why I didn't think about doing this sooner. I'd heard horror stories of this is the worst surgery, the most painful surgery. But surprisingly, with a lot of the advances we've had in the anesthesia and the pain recovery and the multimodal pain management that we have, most patients are taking maybe 3 or 4 pain pills in the postoperative phase and getting back with a quick recovery. Now, one thing you may have heard about is a reverse shoulder replacement, and this is kind of a variation on the theme of a total shoulder replacement. They're both replacing the ball in the socket, but with the reverse, we reverse it around. And so we put the ball where the socket was and the socket where the ball was. And you may ask, well, why in the world would somebody do that? Well, the French are very smart, and they came up with this concept. And what it allows us to do is do a shoulder replacement for somebody who also has concomitant rotator cuff tears. So their function is not would not be ideal for a total shoulder, because you no longer have the tendons and the muscles that need to move the arm around working well. So not only do we need to replace the joint surface, we also need to somehow take over for the function of the rotator cuff muscles that are torn. So this is a very elegant solution, and what allows us to do is tension the shoulder a little bit better and allow your deltoid muscle, which is the big muscle on the side of your shoulder, to now function as your rotator cuff muscle. So it's very elegant, and it's also very amazing how quickly we're able to restore function. And for these patients, I used to put them in a sling for 6 weeks after the surgery, and now I'm so confident with the materials that we have, and also the ability for these patients to recover. I tell them to wear a sling for comfort. And so some patients, they don't even want to wear a sling, so I literally have them in a sling for a day or two. They have very few restrictions, and these are some of my happiest patients, because they are waking up the next day saying, I'm in less pain than I've been in the last 20 years. So really a neat solution using some simple physics. So that's what a reverse shoulder replacement amounts to. Let's talk a little bit more about rotator cuff tears. I've talked about arthritis, we've talked about rotator cuff tears, but this is a thing that really we see more and more often, and this can either be twofold. It can either be an acute tear where somebody falls, lands on their shoulder, and sustains a tear to the rotator cuff muscles and tendons, or it can also be degenerative. And we see quite a few of these scenarios where we have factories like BMW and Freightliner, and we have all of these overhead laborers in our supply chain who are doing 12 hours of labor every day, sometimes in an overhead position, and these rotator cuffs take a toll. And I mentioned this earlier, but 50% of our patients over the age of 65 will have some type of tear. And most of these are not symptomatic, meaning most of these patients don't even know they have pain or swelling, and certainly won't need a repair if they're not symptomatic. It's the ones that are, night pain with any type of overhead activity, or weakness or inability to perform their overhead labor. So these are the types that then we need to have that nuanced discussion, say, all right, this is a tear that may need to be addressed. So here's a little case study. I had a 49-year-old male present to my office. He had fell. He was pumping gas at the gas station, slipped on some oil, and landed from a ground level height right onto the concrete. Well, he had a shoulder dislocation. So that meant that the ball popped out of the socket. So he had the shoulder dislocation, and they took him to the ER. They were able to reduce the shoulder in the ER, but and everything looked good on the x-ray, but unfortunately he couldn't lift his arm above his head, because he had torn most of the tendons in his shoulder that allow us to function as a rotator cuff. So he not only presents with loss of range of motion, he's painful, and he's also weak. This is a bad problem for a 49-year-old male with his dominant arm. So our solution for him, and this is an MRI that we got, you can see the arrows, are representative of pain, but also where he has the injury. So he's torn the rotator cuff muscle, so the black line should be at the top of that ball is retracted all the way back to the socket. And then on the view on the right, his tendon is actually displaced as well. So he's no longer able to use the shoulder as he needs to for a 49-year-old male. So my solution for him was, I said we could do this, we would do an arthroscopic rotator cuff repair. And again, this is a demonstration, a nice little animation, but just to kind of give you the anatomy again. This is right shoulder, and we were able to use these little purple and the blue. Those are called cannulas, so that's representative of the little cannulas that we can then pass our camera or our instrumentation through those little sites without losing our trajectory into the shoulder. The glenoid is the socket, and then the humerus, that's the ball. And then there you can see the rotator cuff. So it's comprised of a muscle and then a tendon, and then the tendon inserts into the bone and allows you to move the bone in the direction when you pull that tendon. So you can see the tear. That's a small tear that's represented in this image. Our gentleman had a very large tear involving 3 of those tendons. But what it allows us to do in an arthroscopic fashion is to pass sutures through the tendon. So it's a very strong, robust tissue, and we use some suture material, just like you would sew up your pants or your pant legs. But this is very strong, reinforced suture material. And sometimes it's absorbable, sometimes it's non-absorbable, but we're able to take a little suture passer, pass it through the tendon in a little weave pattern, and then insert this into anchors into the bone, and then restore the anatomy. That's what we're essentially trying to do, is restore the anatomy, repair the rotator cuff. And so it's a lot of sutures going back and forth, but that's the image, and there's the anchor going in. I'm going to play a little animation now that you've got the visual. So I'm going to walk you through this, and this is what it would look like in real time. Now, this video takes about 2 minutes, but the surgery, if you were to have to undergo the surgery, would take about an hour and a half. So we would need to identify the tissue. We would also make sure that if you had any inflammation or bleeding inside the shoulder, we would evacuate that with a fluid. A lot of times, we'll also take our camera and we'll assess and make sure that we didn't miss anything from the x-rays or the MRI or the ultrasound, and make sure there wasn't some type of hidden injury. So that was what we would call the diagnostic portion. And so there's the camera on the back of the shoulder. Now we just brought in a little grasper through the cannula to tug on the tissue, make sure that tissue is going to come over nicely. Now we're using a little Dremel tool called a shaver, a motorized shaver, to freshen up the bone so that we have a good bony bed. Now we're punching some holes in the bone with a little awl. And then on the inset, you see a little anchor. It's pretty neat. It's called the little screw-in anchor, and it's absorbable. It's made out of basically coral material, tricalcium phosphate. So just like you see the coral in the ocean, this is some nice engineered coral type material. And now it's attached to sutures, and we're able to then load that suture from the anchor, pass it, punch it through the tendon with a little needle device, and that allows us to pass that suture. And then we can grasp it through another cannula. And then we're going to do another suture, different color, so we don't get mixed up and get confused and crossed, because you'll have sometimes 6, 7, 8 strands of the suture all across the joint. It gets to be a little suture madness, as we call it. So we got to keep that all oriented, and that's why I've got assistants in there helping to make sure we've got grabbing the right suture strands. And now we're going to do a little crisscross weave pattern, and then we're going to use another anchor. And now we've got a good secure fixation and a good tension-free repair. So we've restored the natural footprint of the tendon, but we want to make sure that we haven't tugged on this too tight where it's going to possibly rip through the tendon. So it's a very nuanced feel for the tendon to make sure we have this right and restore the normal anatomy for our patient. And there's that final anchor screwing in. Pull that out. We're going to cut all those sutures. Sometimes that's the best part. Now we look at it. This is the finished product, and there's our little suture pattern right across the top. So you just saw in 2 minutes what sometimes take us sometimes an hour, 2 hours to do with the rotator cuff repair. And if we were to look inside with our camera, that's what that picture would look like before. On the left, you can see the torn tendon edge, and there's the bone, the footprint for the bone. And then after the repair, after all that suture madness, we've got a crisscross, we've got little knots, we've got sutures crossing over the tendon, securing that to the bone. And then hopefully over the next 3 to 4 months, that tendon will integrate into the bone just the way God made it, and have it kind of mature. Now, the problem is my patients feel great generally at about 3 to 4 weeks. And now the hard part for me is to tell them not to do too much. So I have to put a governor, put some restrictions on them and say, okay, I'm going to allow you to go back and you can go out walking, or you can do some easy activities, but I'll have to restrict them from at least 3 to 4 months from doing any heavy lifting. If they're in a labor type job, we need to talk to them and we need to modify some of the activities they're going to do for their job. So if they're having to do a lot of overhead lifting, strenuous work, we may hold them back for 3 to 4 months until that tendon is completely healed. But generally, this is one of the most rewarding surgeries we do for our patients because we're able to allow them to get back to what they want to do. And the patients are very satisfied because they can go back with the overhead activities, they can go back to swimming, golfing, and this is something that we do on a routine basis. So we've just covered total shoulders, reverse shoulders, and arthroscopic rotator cuff repairs. And that's going to end our presentation. I'll be happy to take any questions from our audience. And just a reminder, I have 2 office locations. I have one at the Mary Black campus in Spartanburg. That's right in the Hugh Black building and right next to the Mary Black Trail. Very nice location we have there. And then convenient for our Spartanburg crowd. And then for in Gaffney at our Cherokee location, we are just to the left of the hospital. And we've been in that office now for 3 years and be able to serve our Cherokee community there as well. So we have 2 locations to best serve you. Thank you again, and look forward to answering some of your questions here.
Thank you, Dr. Colbath. We have received a few questions. First question, what are the treatments for frozen shoulder, and can you have repeat frozen shoulder?
That's a great question. We have a lot of people come in and say frozen shoulder, and that's when you basically have shoulder stiffness. Frozen shoulder is a kind of common term for what we call adhesive capsulitis, and that can happen either from it's basically when your shoulder gets a lot of inflammation really quickly and it's trying to heal itself, and unfortunately it does too much inflammation and it creates a lot of stiffness, red irritated tissue. And we see this in a couple of entities. We see it, diabetics get this very frequently. For whatever reason, their tissue quality and their body's response is accelerated, and they wind up getting adhesive capsulitis a lot more often than the general population. So they will present with a pain, stiff shoulder, a lot of night pain, and very limited range of motion, to the point where they want to be able to touch their face or comb their hair without excruciating pain. Our general treatment plan for this is to maybe start with an injection to help with a steroid, get the inflammation down, and then get these patients in with physical therapy so they can start to get some motion back. It's kind of trite, but we say motion is lotion, and sometimes that's the only thing patients will remember when I tell them they've got a frozen shoulder, but I want them to get some motion, and it's a hard task. It's a hard ask for me to say, I need you to get this shoulder moving when it's painful. So we try to get the pain settled down. We get them in with a structural physical therapy program. And by and large, I'd say 95% of our frozen shoulder patients don't require surgery. It's only in the rare cases where they've been refractory to long-time physical therapy, multiple injections, anti-inflammatories, and then if they just have recalcitrant frozen shoulder stiffness, that we would then even discuss surgery. And if it was a surgical issue, most of the time these patients don't present with a rotator cuff tear. It's just inflamed tissue. So my task is to go in arthroscopically, release the tissue, and then I'll have them in a sling for about a day at the most. So I have them in with physical therapy the very next day so they can start moving and get some motion back. A lot of times I'll even recommend aqua therapy. So we have a great aqua therapy location at the Hugh Black building. We also have one at the YMCA. Getting these patients in the pool is some of the best treatment that I've seen because they can be in a buoyant environment in the pool. They have less pain. The water actually helps with their pain, and they're able to start with this motion a lot less painfully than they would if they were on land-based physical therapy. So we have had some great wins at the Y with the aqua therapy program and our physical therapists there. So, but that's frozen shoulder. If you've probably heard that term, so stiffness. Mm-hmm.
Next question, please explain referred shoulder pain and some of the possible causes.
So referred shoulder pain that basically means that the pain is coming from somewhere else, but it manifests as shoulder pain. We see this a lot with people who have maybe neck degenerative disc disease, or they have neck spasms, and the pain And think about it, we saw in those images where the muscles connect from the shoulder and go all the way up to the neck. So we see that a lot where you may have a muscle spasm in the neck strap muscles, but it's actually creating shoulder pain. So just like Mom always said, you've got to have good posture, you've got to sit up straight. So a lot of times referred pain to the shoulder can be another cause, either neck pain or just poor posture. So we have to sort that out. And again, remember when I talked about the shoulder injections can sometimes be diagnostic and sometimes they can be therapeutic. Well, sometimes if I inject the shoulder and I examine the patient after the injection, they still have pain, then I'm going to start thinking about some other causes such as neck pain, or sometimes you can even have, surprisingly enough, gallbladder symptoms can refer to the shoulder. So that would be referred shoulder pain. So a lot of things that can cause shoulder pain, it's not always the shoulder.
Okay, next question. Should I use ice or heat therapy to treat shoulder pain?
I get asked that every week. And so I would say whatever feels best. There's no study that conclusively says ice or heat is better, but we do know that both of those work. And all we're trying to do is stimulate blood flow to the area. We know that ice works well, particularly for initial injury, for swelling, helps dampen some of the inflammatory response. But in the later stages of an injury or recovery, alternating ice and heat is very good because you're getting a contrasting temperature gradient, and that induces a lot of things that go in at the biomechanical level, not only for blood flow, but also for your cellular systemic response to kind of create this healing process. So really it's whatever the patient tolerates better. And I do recommend alternating. I think those are very helpful, but ice at the initial part. So if you have an injury, but then later on, ice and heat alternating are a good way to go.
Next question. I have a burning sensation that begins at my shoulder and extends to my hand. What could be causing this?
A lot of times people will say, well, is that carpal tunnel? Is that neck pain? Is it shoulder pain? And again, going back to the referred pain, that's what we have to sort out. Surprisingly, some of the nerves that innervate the shoulder are not as nuanced, I would say, as the nerves that supply your fingertip. You have millions of nerves going into your fingertip where they're not as sophisticated going into the shoulder. So a lot of times, even though you have shoulder pain right here on this aspect of your shoulder, the nerve that supplies that is not as sophisticated. It's called the axillary nerve. And so sometimes it will you'll get the sensation that it's going down into your elbow and your brain's just not processing that as well. But I have a lot of patients who will complain of the exact pain that you just described. And then once we give them the shoulder, all their pain goes away. And once we give them the shoulder injection, their pain goes away. Now, again, if I gave them the shoulder injection, pain doesn't go away, then we're going to start looking a little bit more into possible carpal tunnel symptoms, tennis elbow symptoms. So that's where we have to start scratching our head and looking at some other causes. But generally, you can have a lot of referred pain down the shoulder and into the arm just with simple rotator cuff tear. That's one of the most common symptoms that we see.
Okay, our last question for today. When should I seek medical attention for shoulder pain?
Certainly. So I know a lot of people have wanted to delay care due to COVID and a lot of the restrictions that we've had, but I would say if it's affecting you with your day-to-day activities, so if you've had chronic shoulder pain for over a week or two, and you're disrupting your sleep, you're having pain with overhead activities, you're having weakness, or basically inability to kind of carry on with your day-to-day routine, and it hasn't gotten better with ice, heat, Tylenol, Advil, and just kind of tincture of time. That's something to at least bring up with your primary care doctor or ask whether a referral to a shoulder specialist would be advised. And then obviously, if you've had an acute fall or an injury and you have any of those above symptoms, certainly don't delay care. Just go ahead and get reassurance that you don't have a fracture. And possibly you don't have rotator cuff tear. And a lot of times we can do that with a simple x-rays, ultrasound evaluation, and then guided physical therapy. But the sad cases are the ones that have been delayed for 6 months or a year, and there's something that we could have done earlier intervention that would have helped maybe alleviate some of their issues and their pain and suffering. So we like to get them up and moving I want to thank everybody for their attendance. This will be available for recording afterwards as well, and we'll have some links for this. And again, thank you for your interest. And if you have any questions, please contact us and we'll be happy to see you. Have a great afternoon.